I suppose I should begin by saying, G'day Worcester. Tells you where I come from, doesn't it? Stories, I think, often recognised as part of the fabric of life. And we all love a good story. And I hope you find where that fits into my narrative over these next 25 minutes or so. Now, we heard this from Keith, and it was alluded to by Steve, but these luminaries also talk about the idea of the importance of engagement with those that we look after. So we see on this slide the ideas of words coming out, like include. In other words, involving the people we look after with what it is that we are trying to do for them. Listening, involving, all of these are aspects of engagement. The trouble is, and I absolutely love this word by Talisha, she talks about that when we are looking at our form of communicating to people, often it is a case of saying, how do I give you as much information as possible within the shortest period of time, because I'm flat out busy, you need to know all this stuff, and here's the tsunami. How often do you experience, I do, I know our patients do, they've just had a good 3 or 4 minute diatribe, and 30 seconds later, 98% of it's gone. Go in there and see your GP. Oh, yeah. 30 seconds later, I don't remember most of that. Now, we know clinicians are time poor, and so this is really the context that we are looking at having this little bit of a talk. And if we're going to be trying to get our information across, how can we do it perhaps a little bit differently? The value of what we will see when we talk about stories shortly is to actually say to people, how do we relate? What is it that you like to understand? How do you prefer your communication? Some of us are great with words. Most of us are much better with pictures and mental images. It's lovely if a message is memorable. I think you've won if somebody can recall what it is you said 5 minutes later. That's a good start. Because once you get to this hair colouring, forgetfulness is a superpower. Now, Talisha's also gone on to talk about patient-centred communication. She's talking about here in that middle area there that an element is ensuring that people understand the information about their health condition. That really is going to mean more than just nodding. Yeah. Because so often, don't you see it? That, yeah. But then they step outside of the room, or they look at real life, or they engage with what they normally do each and every day, and the yeah in the office becomes a nah. So, how do we actually then help people to understand the health messages we really want them to have? How do we encourage them to be actually key stakeholders in what we want to do for the care, which is care about them? It's also their care for them as well. So this is where the idea of analogies and stories come in. If we look at the dictionary version of things, an analogy says it's a comparison between one thing and another, whereas the story is a description that can be true or imagined, but it's usually about events. So let's look at just a couple of examples of analogies. Where I work in a rehabilitation environment, we're dealing with usually an older age group. And it's amazing the number of folks in their 80s, 90s, and even older who just absolutely love the skin they're in. No, not at all. They talk about their skin, how it presents, how frail it is, how it's thinned out and wrinkled and everything like that. And one way to help people understand the changes through life with their skin may be using that idea of banana. You get your lovely fresh banana, and how robust and resilient is that flesh as you peel it. And then you get the riper banana, and you just realise how thinned out, how much weaker it is, how much more easier it is to be torn. We say to some of the oldies that I have the great privilege of interacting with that you're not old, you're just ripe. Another way of perhaps understanding what goes on with deeper tissue injury You know, we don't have a wound here as such. You don't have a break in the skin, but is there damage? There sure is. So when we look at a bottom like this, we may not actually call that an ulcer or an open wound, but there is definitely trauma there. And if you equate that to the changes that may have happened to a piece of citrus over a period of time, that's really well discoloured. That piece of citrus is not an open entity, but if you were to dig into it, boy, you'd find the pulp there doesn't look like it normally would. So that could be something as a similar thought to what that bum may be like as we go deeper into those tissues. I really like this idea that if I'm going to be up here talking to you about facts and figures and all of this stuff, that's all great pieces of data, and we need data. Data guides us and directs us. Some of us love it, some of us not so much. Some of us will remember it, some of us won't. But what might help bring those points together is actually an analogy or a story to help us actually see what these data points make up as perhaps a bigger picture. Dear Matt, thank you, Matt. Placing facts, especially medical ones, in an analogy or story is how human beings want to hear things. I think Matt might be right, you know. A good analogy will keep our interest, it draws our attention, it may help us to recall things. So when we were in that doctor's rooms and he was talking about the idea that, okay, you probably need some compression and that compression will help us take fluid out of your leg. Oh, that's brilliant stuff, but how am I going to remember that? What if we're talking to the nurses who are there in that lovely unit and they're trying to tell us as to why we need to clean wounds? Why can't I just run a little bit of saline over that wound or get my favourite plastic faucet with my cotton bud and that little bit of saline and just stir the porridge a bit? Surely that's good enough, right? Well, if we've got a good analogy, it may help us remember things to change practice. Because analogies are good just not for our patients, but they may actually be good for us as clinicians, particularly as we look at mentorship and those who come along to try and learn what we're doing behind us. One of the ones I like to use most, particularly as I'm trying to encourage our younger nurses to not be afraid to really clean wounds well. For the younger ones in this room, I must explain this slide. There's a hand holding a sponge, which actually is abrasive. There is a sink. In that sink, there is water. That warm water has something in it called detergent. This particular implement is a fry pan which possibly is not going to see something you know so well called a dishwasher. So in the days of old, when knights were bold, we actually had to manually clean dishes. It was a real thing. Now, if you had a fry pan and you had it full of oil and some food remnants, you could just stick it underneath the running water and hope that it kind of cleaned it away a bit. You may even wish to do that before you put it in the dishwasher. Well done. But has it really helped you clean away the grit that was there on that saucepan? So we put it into warm water. That warm water has a detergent, otherwise known as a surfactant. You get your sponge, which is a bit abrasive, and you actually scrub the tripe out of your fry pan, continuing and continuing until all of the debris is gone from it. A little bit like getting to pinpoint bleeding in a wound in a way, isn't it? The way you think about engaging with your fry pan is not too dissimilar to what you may choose to do with a wound. Using surfactants, warm solutions, and not being too scared to give it a damn good scrub. So maybe that surfactant can help. But I realise that we somehow need to be mindful of what our analogies could be, because what if somebody's never seen a sink and never used a detergent? Like some of you, for instance. I love this. Dudley said this, and I think this is really the foundation of why this fits into this theme, right? Of do we have time to care? I don't know how Dudley measured this. I'd like to ask him one day. It could be cool. One good analogy is worth 3 hours of discussion. Wow, that's impressive. But how did he come up with that? I don't know the answer, but I'm just going to run with it. So that's good. Let's see if we can come up with such a good analogy. So what is a good analogy? It's something which is familiar, ideally short. You don't want an analogy that goes over 15, 20 minutes. Usually we're better talking about short captures, and the more visual for many people, the better it might become. As we've been collecting analogies over the course of this year, I found that a lot of people actually have very similar material or topics that they wish to address, but yet they all come at it from their own perspective. And that's really a great thing about analogies, is that you can all say, I want to talk about this, but your angle and your version is slightly different to mine. The whole point of an analogy is to allow somebody to have the aha moment. That light bulb's just gone on. The way you said that, I can now understand. So it's nice to have a whole suite of them, because someone somewhere will say, that for me made a difference. The analogies, they need to have a starting place so that the patient, when the patient's hearing these analogies, it needs to be relatable to them. Let me step back for a minute, because I'd like to hear that you hear an analogy which comes from Japan. These snowfields in Japan recorded straight to an iPhone. Thank you, Fleur.
Hello, my name is Fleur Tresize and I'm a nurse practitioner in wound management. Gary Bain from The Wound Guy has asked me to share with you an analogy about moist wound healing that I often incorporate into my teaching about wound healing and wound repair that can assist others in, visualising and understanding concepts about moist wound healing and about dressing selection. Now, we've all heard of the story about Goldilocks and the three bears, and how Goldilocks found the chair that was not too big or not too small, but was just right. How she found the bed that was not too hard, not too soft, but was just right. And found the porridge that was not too hot or not too cold, but again, was just right. Now, I use this Goldilocks principle when I talk about moist wound healing and the wound bed. So we're looking for a wound bed that is not too wet, a wound bed that is not too dry, but one that is just right. And you can then incorporate that also into dressing selection to help you choose the most appropriate dressing that you might need to manage the level of moisture that is there on the wound. So if you listen to any of the talks or the teaching that I do in relation to wound management, you'll often hear me talk about the Goldilocks principle. I hope this analogy has helped you in your wound care journey. Have a good day.
Thank you, Fleur. There's 2 slides coming up about the advice given to us as to how you construct an analogy or a story, but particularly the analogy. The first thing to really make a decision about is the point that you want to get across. Does it even need an analogy at all? If it's the kind of thing that can be said simply and it's understandable, then maybe that's just what you deliver. But is it necessary to actually devolve this into some form of analogy? The analogy needs to be familiar. Now that just means not just from a point of view of what might be language, but also culture. People have different ideas and backgrounds, and you get to know your patients, and as you do, you might find that there's certain analogies which will resonate, whereas other mental pictures will not. We need to make sure that when an analogy is being delivered, just like Fleur did, does that person hear the message that you actually intended to deliver? So never leave an analogy unasked about. Deliver it and then delve into it to make sure that your message was actually what they heard. Now, this is one of my favourites. Frank Guerrero is a friend of mine from South Australia. He has a unique way of delivering, just as he does with his wonderful hairstyle, so different to mine. Listen to this. Frank from South Australia.
My name is Frank Guerrero. I'm a nurse practitioner of vascular surgery from Flinders Medical Centre in South Australia. I've been kindly asked by my friend and colleague Gary Bain, the wound guy, to speak to you about a metaphor I use when teaching people about the key cells in the inflammatory response and how they impact wound healing. A building site is a great common use metaphor for wound healing, as it typically involves an area that is busy with activity and has an end goal of a nice looking completed building, or in the case of a wound, healed tissue and new skin. Like this building site that you see here, wounds start as a messy area filled with cell debris post being damaged. Now this damage is much like a freshly knocked over building, with crumpled bits of cells and proteins scattered throughout the wound bed, much like bricks and building debris. Coupled with this are often damaged blood vessels and lymphatic vessels, like ripped up pipes or damaged leaking pipes. And they in turn bring in the first responders, neutrophils. These guys act like scouts, and in a way like building site managers, who take out bacteria and also send out messages to the rest of the body's immune system to coordinate a cleanup of the building site, so bringing in new cells, releasing text messages to bring in new cells, new types of cells to get the job done. Accompanying these neutrophils are macrophages, and they're like a demolition crew or a cleanup crew, and they clean up the damaged building area, which are cells, and crush any random bacteria that may be floating around the site as well. Once clean, the neutrophils then signal the next phase, the laying of foundation and the placement of scaffold, bringing in fibroblasts. Now these are my all-time favourite cells, as they're the heavy lifters, or tradies as we call them in Australia, who do the heavy lifting of wound healing, placing collagen to scaffold the building site for new walls, windows, and eventually the roof to be built, so your wound to be healed. Finally, access to the building site is governed by an enzyme family known as proteases. And these act like security guards for the building site and govern which type of cells can come in and out of the site. So some common names for proteases that you might be familiar with are matrix metalloproteases. So what happens when this process is compromised by a chronic health condition such as venous insufficiency or diabetes? Well, typically, you see things stall in the inflammatory phase, meaning that the governance of the building site goes a bit haywire. So rather than the lovely orderly process I've just described, the site managers, remember the neutrophils, overstay their welcome, and they release mixed messages. They release signals that in turn make the security guards, the proteases go haywire, and they outstay their welcome as well. So if you can imagine a building site where access is no longer orderly, you have tradies building walls whilst a demolition team is still active in the site, and so there's like walls being built and then being knocked down at all sorts of random times. And there are active resources that are being brought in, but they're being scattered about the building site in a random fashion as well. You can imagine that that would not be good for getting the building finished in a timely fashion. And this is exactly what is going on with chronic wound healing, and why it's so important to fix the root cause, or as we say, underlying etiology, to ensure that the building site gets back on track to being finished and healed.
Thank you, Frank. Now, we've seen a couple of analogies as we've gone through. I mean, what Frank just delivered is an awesome way of looking at wound repair, but that's for us. Show that to a patient and you're going to lose them. So we've seen some analogies where perhaps simpler things like the banana skin or that piece of citrus could be useful. Who is your analogy intended for? Because they are great tools to teach health professionals. But they can also be brilliant for communicating messages through to the people you're wanting to look after, your patient population. So a check here from Helen is to say that, well, when you have a message to deliver, when you're designing your analogy or your story, you want to make sure that somebody's understood the message that you've delivered, but then it's great to have the check with your colleagues to independently look at what it is that you've designed. Always have somebody as a backstop with fresh eyes, fresh ears to say, oh, that's a good one, or I didn't understand that, or what do you really mean? Or the message is confused or a bit lost. And then, in the order of the whole theme of this conference, there is one slide left to go as we consider timeliness today, and indeed the utilisation of saving time, maximising our effort within our workplace. And that is to share this with you. Stories are memory aids, instruction manuals, and dig this, I like this. Stories can be the backbone of sharing a moral compass. Not bad, really, when you think that sometimes it just starts with something as simple as a picture put to words to now say, aha, I am now an empowered client, an understanding clinician. I have a mental image, I have my data points connected, now I'll go forth and perhaps do. Thanks very much.